Perfect. Well, thank you so much, Barry, for that introduction. And thank you, Hunt, for inviting me to speak today. Again, my name is CARRIE McClellan. I am the Outreach Manager for Elder Help. And through my role at Elder Help, I am going into the community to let people know about our services through our organization so that people can know that there are options to help age in place. I also am the first point of contact for any potential volunteer who wants to join our team. And I oversee our family caregiver support program. So a lot of what I will be covering today is much of what I talk with our family caregivers about when we're looking to plan. Just a brief about Elder Help and our mission. So we really focus on supporting older adults who are still living in their own home out in the community, who want to maintain their independence, but are perhaps looking for some additional assistance to be able to do that successfully. So I'll run through our services just briefly, and then I'm going to move forward and I'll touch on these throughout as well. But we, again, are wanting to maintain independence with our clients. So we offer information and referral service. That's for anybody, whether it's an older adult or a family member or a neighbor who's looking for resources. We ultimately connect people to resources to help them maintain independence and live successfully. We offer a variety of calls to check in. So if you know anybody that could benefit from having a friendly call just to make sure they're doing okay, that's something that we do through our volunteers. I mentioned our family caregiver support program. So we offer different webinars that are available through our online library on our website. If you would like to check that out, it's our family caregiver page, and we have them live about every month. We also have our Seniors A Go-Go transportation program, and transportation is definitely one of the most requested services that we get from people in the community. Our care coordination program has social workers involved, as well as volunteers who help with a number of things outside of COVID. During COVID, we are focusing on the most essential needs. So through that program, we're helping to deliver food and essential items, as well as groceries to our clients. So that's just a little bit about those programs. And then our housing services, I'll talk about one of our programs in just a moment, but we're really wanting to make sure that people have the different options available to them and help kind of walk them through that process. So that's a very quick run through, but I want to get into the meat of everything. So a little bit, we know about the aging population. We know that we are going to double people living in our community over the age of 65. That number is going to double in the next less than 10 years. So we're already seeing that effect, and we're knowing that more and more people are going to need some type of support. The fastest growing population is the 85 plus folks. So people are living longer, maybe with chronic conditions or otherwise, but we are looking at those who are going to need some additional assistance. 90% of seniors want to age in place, and about 70% of those individuals will need some type of long-term care support in order to make that happen. So whether that's through family or friends or the community or other organizations that I'll talk about. So what we always want to do, right, is plan ahead. And in order to do that, it's important to know the options. So I'm going to go through each of these so that we can have a basic understanding. I don't have a ton of time to touch on these, but you'll at least get the gist of it. In planning ahead, it's important to assess needs. So that's looking at whether you're considering your own needs or your loved one's needs, but kind of trying to think about what are those needs now and what might happen in the future. So driving is definitely a big shift for people if they're not able to continue doing that on their own anymore. They might need to look for resources to be able to have somebody else take them to the grocery store, to their doctor's appointments. Nutrition and food is very important for all of us to survive. So that's something that is also most requested service for a lot of people who are looking to get their nutrition and their food in different ways. And then of course, advocacy, and that can be, having somebody who can walk them through a process or making sure that they know what's available. And it could also be that they're needing to have social activities and connection. And when somebody needs some of those types of things, they can still live in their own home and they can do so successfully, most of the time independent or with a little bit of support. And when they start to need a little bit more help, maybe they need help with bathing or dressing or toileting, transferring from a bed or from a chair, then they start to need a little bit more formal support. And that could come through home care, which I'll talk about. So kind of starting to think about creating your own support network, who might be part of your team. Does that mean that it could be family members, whether it's a significant other or children, or it could be nieces or nephews? It might also be friends or neighbors or church groups or any other group that you participate with. It might be the Hemlock Society, individuals in your own group who are looking for support, and you might build upon that with each other. It's important to start the conversation now and don't just think about that on your own, but talk to those individuals to see how they might be able to help as well. And then if you don't have many people in your network or you're looking for more community support, there are a lot of great resources within our community. San Diego is very fortunate to have a lot of nonprofit organizations and for-profit that can offer support. I'm just naming a few. I'm really just scratching the surface here, but hopefully this helps to kind of point you in the right direction. If you're looking for transportation options, FACT, or Facilitating Access to Coordinated Transportation, is a really great resource. I've listed their website as well as their phone number. And on their website, they also have a section for volunteer driver programs. So you'll be able to go and look for a list of volunteer driving programs that are available in your particular area. And our Seniors A Go-Go program is one. All of the programs offer it a little bit differently. Some are donation-based, others have services for fee. So you would have to call those specific organizations to find out. Nutrition, so grocery shopping or having meals delivered is really important and good options. So Jewish Family Service offers a number of programs, not just meals or transportation, but many, many others. They're a really great resource in our community, as is Meals on Wheels, who does deliver meals to homebound seniors so that they can continue living at home and receiving the nutrition that they need. Elder Help's Pantry has been operating during the pandemic, and at this point, we're continuing to offer that for food and essential items as well. Just a couple of resources in addition to that is Interfaith Community Services. They primarily focus efforts in North County. So if you live in North County, that would be a good organization to connect with. And Aging and Independent Services through the County of San Diego has a lot of great information and resources available. If you are a family caregiver and looking for support, Southern Caregiver Resource Center and Alzheimer's San Diego are two of the most commonly referred organizations that we connect people with. They offer great educational services as well as support for family members caring for a loved one and the person themselves who might be living with dementia or Alzheimer's. So I'm going to go through what home health care is. So home health care is for somebody who might be discharged from a skilled nursing facility or from a hospital, and they could benefit from having additional services in the home. This is something that would be authorized by a physician, and it's mostly covered by your medical insurance. So it would be Medicare or Medi-Cal. And they would offer things like nursing care if you need injections or wound care, physical therapy, occupational therapy, social workers, and home health aides. You have to qualify for this service, and it is something, again, that would be ordered by a physician to have your insurance cover it. But that is a really great option for somebody who is going back home from the hospital or a long skilled nursing facility if you're needing that additional follow-up. The other option would be home care, and home care is non-medical care that's provided by caregivers in the home. So some of these services would include things like meal preparation or light housekeeping. Could be that when you are needing the bathing or help with toileting or medication reminders, that you hire a home care agency to help out with that service. They can also offer companionship if you're wanting just somebody to be there, or you're worried about a loved one and want to make sure they have somebody who can check in on them more frequently. So a question on who pays for home care. This one is a little bit different than home health care. Currently, the most common rate is $30 to $37 per hour. And that's for having a home care agency caregiver come into the home. It's most often private pay, although you can get services paid for if you qualify for Medi-Cal. You can have in-home supportive services. And the best way to find out about that would be to contact our Aging and Independent Services through the County of San Diego to find out if you would qualify and could get that benefit. The VA has an aid and attendance program that can also help to cover the cost of home care. There are certain guidelines for that, of course, but you would be able to find out more information through the VA. There are also local agencies that can help point you in the right direction for that. Another option could be long-term care insurance. And I've highlighted HICAP here. Our local health insurance counseling and advocacy program is excellent and can help really to review policies if you do already have long-term care insurance, but you're not sure how the policy works. One of their counselors can help you go through that to make sure that you can understand when the time comes for you to use that, you can know what the next steps are. Some of them have a waiting period where you're paying out of pocket for a certain amount of days before the insurance would actually kick in. So it's important to note that. There's also a really helpful guide through the California Department of Aging, and it's called Taking Care of Tomorrow. So that one is worth looking at, and it goes through all of the different long-term care kind of plans and what you might need to do to prepare if you are not currently having a policy, but you're interested in looking for options to get one. And one thing I wanted to note is how to hire a caregiver. So something that changed a few years ago is that now agencies do need to be licensed within the state of California. And it's really important that you do check to see if the agency is licensed, because they've had to go through a lot of different steps to become part of that group that can be located and found through their website. It's kind of tricky to find out if an organization has been licensed. So I did mark down the steps here. You would want to go to the California Department of Social Services and then click on Find Licensed Care, and then find the facility or seek the facility, which is weird because you're looking for home care in the home, but they still have it under facility care. And then you would select home care organization and enter the organization name under facility name. So it's a little tricky, but once you do that, you can search for the agency that maybe a friend told you about or somebody else has mentioned to you, and you would be able to know if that organization has in fact gone through the licensing process in the state of California. If you do plan to hire a caregiver on your own, maybe you want to go outside of an agency because it is more expensive. What's important to note is that you then become the employer. So you're responsible for the taxes for workers' comp and for unemployment. So it's really important to know those things before you enter into a relationship with somebody that's not part of an agency that doesn't already have that safety net in place. And be prepared to have a backup plan. If you go through an agency, they can have somebody come out most frequently right away to make sure that you have the care covered. But if you do hire somebody on your own and they're not able to come and help out, then you would have to find another backup option on your own. Something to just consider. Both options can work, but it's important to know how to do that properly so that you can make sure that you or your loved one is getting the appropriate care. Another option might be if you would like to share your home. So if you have a spare room in your home and if you are looking to have somebody move in, there are many benefits to doing this. It could help you to stay in your home longer. Maybe you are not able to pay the rent. And so you are looking to just have somebody move into your home to simply pay rent to be there so that you can provide that additional income and pay your rent or mortgage costs. It could also be that you are wanting to have somebody come into your home and help with things around the house or with meal preparation or transportation. And so having somebody move into your home could help in that regard as well. It also could give you peace of mind knowing that if an emergency comes up overnight, I have somebody in my home that's available if I need that. One option for doing that is through Elder Help's home share program. And essentially we facilitate matches between a home provider, somebody who has an extra room in their home, with a home seeker, somebody who is looking for a room to move into. And there's different ways that we do that, but it is very personal. We want to make sure that if we are matching people, that it is for a longer term purpose and not a short term, just a few months here or there. Currently, this program is on hold for enrolling new clients into the program because of the COVID-19 pandemic, but we are currently looking at ways that we might be able to resume services, especially now with people receiving vaccinations, and it might become a little bit more safe for us to do that in the near future. The program is not offered all over the county within Elder Help, but the cities of Poway, San Diego, and Vista currently do offer that. Other options would be Silvernest, and you can look up silvernest.com. They help to facilitate roommate matches online. So they don't necessarily get to know you and the other person as we might, but they can also use their online system to help kind of figure out, based on your interests and what you're looking for, who might be a good fit for you. If you perhaps live outside of San Diego or know somebody that might, the National Shared Housing website could be a really good resource for you that helps you to locate what other shared housing options might be available in other areas. So as I wrap up, and I know I've run through things rather quickly, but just wanting to make sure that you have a little bit of that information on how our community does have a lot of great options for making sure that you can age in place if you would like to. And there are options that you'll hear about if you're not able to in just a moment, but it is important to plan ahead, understand those care options, and you can continue living safely and successfully. But it's helpful to know what resources are out there and how to connect with them. So with that, I will leave it up for just a second. If you would like to stay connected with Elder Help, our main phone number is the best way to refer anybody to our various programs, or you can send an email. If you're interested in knowing more about our family caregiver support webinars, or you have a volunteer interest, that would be connected with me directly, and my email is on the screen. If you want to sign up for our newsletter or learn about anything more, our website has a lot of great information. So thank you so much for your time. I know that I'm about at the end of my time here, so I'm happy to answer any questions that might have come in. That is correct. So that is, yep, that's what they do. They're most of the time licensed and bonded, and they're able to have all of those protections in place. So as far as examples of who it might be, we have anybody over the age of 18 could be eligible for that. At least one person in the match would be over the age of 55. So it tends to be the person who has a spare room in their home is the older adult who might be looking to maintain their independence and live there, and they would have somebody move in to do that and help around the house. Maybe they're paying a lowered amount of rent to do that, or it could be that they're just paying rent to be there as a roommate. Maybe the income is what is needed. And it could be also that they are needing home care services, and by having somebody pay rent to be in the home, they can then help to afford that cost. I did see another question or comment come in, and I'm so glad to see that Evie Kossauer is on the program today. Villages they're a great resource, and in San Diego community, we have so many different villages that are trying to support their own communities. So if you're interested in learning more about that, she would be a great resource, or Elder Help can point you in the right direction. But I'm glad to see that question. I would say it's probably lack of, well, I think cost is a huge part of that. But also it can be costly to move out of your home. So there's kind of that tricky part there. I think that a lot of our clients might not have family. And so they're looking for only outside agencies. And if they reach a certain level of care that is needed, that is no longer safe to be in their home with the resources that they have, then it would be for them to move into another living arrangement where they can get all of the resources and all of the support they need under that roof. And I know Sandy will be talking about all of that in just a moment. We don't have many volunteers in the Encinitas area. Our home share program is not one that is operating in there. So it just depends on where our volunteer availability is. In terms of, do we act as a resource or can we find facilities? We tend to refer to the experts who are who are looking for those different options and know all of the different levels of care that each facility can provide. So we would refer to a placement agency if somebody were looking for an alternate living arrangement, because we don't have the ability to go to every single facility, but those individuals stay on top of all of it, which is really helpful for our clients.
Thanks so much, Barry. And I'm going to put up my screen, my slideshow as well. Hopefully I can do it as gracefully as Carrie did. All right.
Bravo.
Well, we're not there yet. Okay. This is what we're going to focus a bit on today, which is, I know that the program is called The High Cost of Dying, but in fact, I'm going to focus a little bit more on the high cost of living while aging. And we're going to look at why leave home, the levels of care and costs, the different types of communities, senior communities, the payment options for care, which I know is of concern to absolutely everyone, and some resources. And then I'm going to do a little proselytizing because I have a crowd, so I have to. To begin with, to understand whether staying at home, either with or without support, or finding a senior community is appropriate, there's some basic factors to explore. And I think one of the things that Carrie said that's so important is that 90% of older adults want to stay in their homes. There are people who actually want to move out. There are also people who need to move out. So let's talk about that a little bit. The first thing would be, what might an older adult identify as a good aging life? And being one myself, I can say that we're looking for health and safety, family, friendship and fun, financial security, and a nice home that feels like home, whatever that means for the individual. What do people love about being in their own home? They love the independence of being able to come and go as they please. They love having their own furnishings and tchotchkes and things on the wall. Many people are connected with their neighbors, and that's extremely important to them. And having a pet can be very important to people as they age, and that's very much a part of the decision they make. But then we want to look at what might cause an older adult to start thinking about moving to a senior community, or it may be a conversation that a loved one has with them to suggest. One of the reasons is that things that they used to enjoy, chores that are things that they used to enjoy now become a chore, like shopping and cooking often brought many people enjoyment, now perhaps not so much. They may stop driving and feel isolated in their homes. Their health needs may have increased, and perhaps they're having difficulty managing their medications or their showering and so forth. The home health care costs are adding up. One of the things that I think is important to understand, I'm working with a number of people who have 24/7 care. That's costing about $200,000 to $225,000 a year. That's not something that most people can manage. Some people feel very lonely at home. As we age, our lives, our world shrinks. People around us may die, they may move away. Our families are very mobile and they move. And so lives become more circumspect. And then sometimes there's caregiver stress. If a family member is providing that care at home, then sometimes it becomes, as Carrie talked about, and there are some wonderful supports in the community, but it sometimes becomes overwhelming and it doesn't become a viable alternative for families. So if a decision is made with the individual and their family that it's time to look for a senior community, let's talk about the different types of senior communities that there are, or really what the levels of care are. Let's focus on that first. The primary ones are independent living, assisted living, and memory care, because they're both licensed together as assisted living, and skilled nursing. I'm focusing on the aspect of senior communities that provide a more fulsome set of options than just an apartment that someone could go to. So I'm really looking at senior communities. And in a senior community, what you'll see here, if you look at the chart, is that as you move up the ladder of levels of care, there are more services offered. So fewer meals in independent living, certainly full meals in assisted living and memory care, and skilled nursing. Transportation is included in all of them. That's a great benefit to many people. It's transportation to doctors, to shopping. In skilled nursing, they don't go out so much, but they will still provide the transportation to doctor's appointments. Activities on site and activities off site. Of course, skilled nursing is not going to have activities off site, but the other levels of care do. They all have emergency call systems. And then the real difference is when we get to the assistance with the activities of daily living. And those activities are showering, dressing, toileting, escorting, and one of the most important, of course, is medication management. And because that can affect all aspects of health. That's not included in independent living, but it is in the other levels of care. As I just dawned on me that I should explain to you that everything's getting a little fuzzy these days. Independent living now has aspects of assisted living to it in some communities, because they want people to be able to age in their new apartment as opposed to their own home, and not feeling they need all the levels of care of assisted living. Memory care is a secured community or a secured unit within a community. So it's very much like assisted living. It has all of the same services, but it's typically a higher level of staffing, because people typically with advanced dementia are not able to define their own needs. They're more frail. they need more assistance. And then nursing and rehab is only available in a skilled nursing facility. Although in assisted living, you will often find that there are nurses. Typically, I think licensing requires 40 hours a week. Some actually have nurses 24/7, but it's not required. And there are limitations on the kinds of services that those nurses can provide. So in assisted living, for example, residents cannot have any kind of tubes. They can't have a feeding tube. For that, they would need to go to skilled nursing. And then the monthly costs. In independent living, it can be anywhere from $1,200 a month to $10,000 a month. Of course, it all starts with real estate, where the community is located, what kind of amenities the community has, and so forth, as well as what kind of apartment the particular resident chooses. Assisted living and memory care then, of course, starts adding cost on, because in addition to the additional staffing, there's also more liability to the community. And so that's going to run anywhere between $2,200 a month and $15,000 a month. And skilled nursing, if it's at the private pay level, will be anywhere from $7,500 to $15,000 a month. So it certainly is not inexpensive to age, which is a difficulty that we as a society, I think, have to come to terms with at some point. But right now, that's our reality. So the types of communities we have, Carrie talked with us about shared housing, which is a fabulous option for many people who have particularly limited funds. Boarding care homes are assisted living and memory care. They're small group homes. They're typically 6 residents and 2 caregivers at all times. And it's a wonderful setting for people who are frail, because the ratio of caregiver to residents is so good. And the fact that it's a small environment. It, however, doesn't have the same kind of cognitive and and social stimulation that a larger community has. So it depends very much on where someone is in their aging process. There are, of the larger communities that are out there, and I'm sure you've all seen all the advertising that goes on, because it's a very competitive world. There are some, just a few, that are just independent living only, but they will still provide meals, transportation, activities, and so forth. And then there are others that have independent living and assisted living, or independent, assisted, and memory care, or there are some that just have assisted and memory care. So they're all different kinds of combinations, and it becomes a question of finding what someone's needs are and what kind of community meets those needs. And of course, there are skilled nursing facilities. Most of them are independent. Some are attached to what we call continuing care retirement communities, which are communities that have all levels of care. So someone can move in the independent part of the community, and as they age, move to higher levels of care. But most skilled nursing facilities are independent, and the reality is that most people spend a maximum of 30 days in their lifetime in skilled nursing. They're there for rehab. There are only a few who are there for long-term or custodial care. But the continuing care retirement communities are out there. There are 2 different types. There are those that require a fairly sizable entrance fee, and then a monthly service fee. And there are a few that are rental. Most senior communities in San Diego are rental communities. It's month to month, not a long-term contract. And so a resident can move out with 30-day notice. So it's very flexible. So how does all this get paid for? Primarily, it's private pay. Most people feel that Medicare should be paying for it. It doesn't. Medicare only pays for medical care. It does not pay for supportive care. So independent living, assisted living, and memory care are private pay. Some people have long-term care insurance, which, depending on how it's written, because every policy is different, may pay for assisted living and memory care. Typically, it's not going to pay for independent living unless people are also getting some add-on services at that time. There's a program through the VA called the Aid and Attendance Benefit for those veterans or spouses of veterans who served in the military during a time of war. And there are very specific dates of service. We now in California have what's called the assisted living waiver, which is for people who are on Medi-Cal, so they have very limited resources, and they can, and have a level of need. They can move into certain communities that accept that waiver, which is it's a limited number. There's a tremendous demand for it. It's about a 2-year wait list at this point. There are a few communities that offer some limited financial assistance, but they're very few. Medicare will pay for rehab in skilled nursing. So someone who goes into skilled nursing after a broken hip, after pneumonia, needs to build strength, Medicare will pay for that and supplemented by Medi-Cal as long as someone is continuing to improve. Once they've plateaued, they need to be discharged. And Medi-Cal will pay for people in skilled nursing for custodial care, but it becomes very difficult to get into that program as well. There are very few beds available. It's typically following a rehab stay. There are lots of resources out in the community, and obviously we can't go through them all. I think Hunt said that it's going to be on the website, on the Hemlock Society website, so please feel free to access them. This is just how to contact me if I can be helpful, but just one moment for my philosophizing, proselytizing, which is we often talk about the right to die, but people also have a right to live the way they want to live. And people who have the cognitive ability to be able to understand the consequences of the decisions they make and who want to stay at home, even though that may jeopardize their health and safety, it may shorten their lives, have a right to do that. And it's very hard to be the loved one watching them make a decision that we think is not the best decision for them, but they truly have a right to do that. Okay. Thank you. I think the folks from Hemlock Society probably are better equipped to answer those. I will say that all communities require the paperwork that indicates what people want for themselves for end of life. And it's always the individual and their family who make the decision, not the community. But go ahead, Faye.
Well, if the paperwork is in place and you've named somebody to make the decisions for you, if you're unable to speak for yourself, that person, your healthcare agent, their wishes should be honored on your behalf. Now, if they're not honored, that's another story, which may require legal intervention. Final Exit Network has offered to take cases to court where end of life wishes are not honored, which are written down and legal, but they're not honored. Like, you do not want to be fed or hydrated. That's really complicated, this whole thing about VSED, voluntary stopping eating and drinking. And presumably that will be a court decision, because some of these facilities require that food be presented to you. And if you say no spoon feeding, they may dispute that. So it's very complicated about making sure these wishes are honored. If you have a do not resuscitate order, and especially if you have a necklace or bracelet that says that and you're resuscitated, again, this may be a legal problem that may have to go to court to be resolved. And those are difficult decisions. So there's a few places Final Exit Network has agreed to provide these legal interventions if they're necessary. Theoretically, they shouldn't be, but sometimes, and I've seen instances, for example, in long-term care facilities like where I live, where the CVNs or the nurses say, no, I can't do that. I can't stop treatment. I can't not give antibiotics when somebody has a urinary tract infection. And so the person's given antibiotics, or the person's given spoon feeding when that's a violation of what the family has already said they want. So these are not easy decisions to enforce all the time.
Yeah, thank you,
Not
Faye.
very helpful, no.
No, thank you. That was helpful. I think one thing that is important that I remember, and this is why it's great to be a member of Hemlock, you learn stuff. And one of the things I remember learning was that it's very important when you go into an institution to have in writing a document which spells out what you are not allowed to do. At least that's the intent. You should strive to have a legal agreement with that institution that spells out exactly what you're permitted to do and aren't permitted to do. So that would be the best way to assure that you get what service or assistance you think you are getting.
Well, thank you, Barry. It is a privilege to be speaking to the membership of this organization that I have gotten involved with. I want to share a screen. Hopefully I'll do this correctly. I'm not an expert at this. Let's see. How do I get rid of this screen? Maybe here. Okay, so the initial title was Options to Exit Early. That's after Derek Humphrey's book, Final Exit. And then I added when enough is enough. And it's very important to think about that, when enough is enough. So I'll go back to my speech and debate days in college, where they said you're supposed to tell people what you're going to talk about quickly, then talk about it, and then review what you've talked about. So this is the brief outline. The introduction: dying can be a painfully slow and expensive process. We're kind of learning that from our first two speakers. The concept of medical futility, I'll get it out here, not fertility, futility, is alive and well in the United States. And very importantly, any decision to exit early should be made only after frank talks with your physician and your family. It's not to be taken lightly, and I'll go into that in more detail. So you got the first part, the introduction, and then assuming that you're finally coming to the point, you know, you have exhausted all the medical treatments that you think can benefit you, and your life is continuing to devolve and worsen, then really you have to ask a question: are you exiting early with a prognosis of life expectancy less than 6 months? Because that opens up certain options. Or even though you are seriously debilitated and in severe and unbearable pain or otherwise not comfortable, are you exiting but your life expectancy is more than 6 months. And then I'll be giving some information about websites. You're welcome to take notes, of course, now, but both our website and End of Life Choices California has a lot more information than I'll be able to give here. Okay, so with that, I will go ahead and maybe I will see if I can stop sharing and then just give you some information. You know, there's been a huge transition in what age and when and how people die. Used to be a high percentage of people died much earlier in life and quickly, but our medical care has been allows us to live in a pretty degenerative way for many years. And so the reality is most of us are going to eventually die from a prolonged, progressive, degenerative disease. It will commonly entail multiple visits to the emergency room, going to the hospital, getting tuned up with many procedures, then going home for a while, only to repeat that cycle. And unfortunately, many of these terminal illnesses like metastatic cancer and chronic lung and heart disease are also accompanied by severe pain or mental malfunctioning. And we try to take care of the pain with medications, and unfortunately those medications often have side effects anywhere from constipation for narcotics to cloudy sensorium and more confusion than even the illness is giving us. So this daunting combination of pain and anxiety and worry often pushes the panic button, and we call 911. And the EMTs are more than happy to rush in and extract us from our house, take us to the ER. We have excellent emergency room facilities in San Diego. And there's a pretty good chance that they will bring you back from the brink, potentially many times, only to go home again and repeat this process. So it's important to realize that that is the milieu that most of us in our 70s and 80s and 90s exist in. And we have to decide how long we want to continue that. It's also important to know, and I think we do, that physicians want to offer us hope, and they are trained to treat us, not really to help us exit gracefully. So it's important to know that there's going to be a bias, unless you bring up other topics, a bias to be giving you any kind of glimmer of hope that the physician can see. So the purpose of this talk is to remind us that if the pain and suffering gets bad enough, or the diminished capacity to live life well, we have the choice of getting off of the treadmill. We have the choice of exiting. That gets into the whole idea, really, this advice from physicians of medical futility. It's really a common practice in the United States for when patients are pretty ill to still have the physician offer them expensive, often very uncomfortable treatments, even when the marginal benefit from that treatment is either negligible or it is less than the pain and suffering that you do through the treatment. A classic example is the second or third line of chemotherapy. Even though the clinical studies don't really show much efficacy, the doctors will often say, well, I've had a couple of patients that did really a lot better than we expected they would. And we climb onto that couple of patients. That is not evidence-based medicine. The doctor is skewing away from really giving you the truth to giving you hope. And you have to decide, do you want truth or do you want unscientific hope? And you're the one that's going to have to ask for more in-depth questions, because the doctor, unless you say, give it to me straight, doctor, I want to really know what my chances are here, they're going to have a really hard time doing that. Just because they're human too, and they don't like to deliver really bad news for people who aren't asking for it. So we've talked about the chemotherapy. Second and third line chemotherapy are second and third line because they are not first line. They either are not as effective or they have significantly more serious side effects, or both. And another example would be family members who see a person in distress, and their immediate answer is what? Call 911, get the EMTs here and get the patient to the hospital. 70% of Americans want to die at home, but only like 20% do. And that has a lot to do with somebody pushing the panic button and calling 911, even though we know we're very close to the end, but we panic because we don't have a plan, and therefore we end up getting to the emergency room and often dying in the emergency room or all by ourselves in the hospital. Now, before we go to the ways we might exit, I want to really go over this caveat about making that decision. You know, life is a very precious thing. And if we have a moderate amount of pain, but on some days we have good days and we can share those with people we love, we want to think seriously about whether it's time to exit. So this is not a talk about the first time you encounter pain or suffering, decide to exit. This is a talk about talking to your doctor and your family about what's important to you and what gives you joy. And are you still getting that joy, even if it's in smaller quantities and less frequent than it used to be. But at some point, I think for a lot of us, we're going to say, yep, enough is enough. The joy is so minimal, and the lack of dignity, of loss of continence and bowel function and forgetting, and just the level of pain that we're enduring is too much. And so what kind of options do we have other than just waiting slowly to die from our primary disease? So the first part you'll remember was, what if your diagnosis or prognosis is less than 6 months? Well, there's some good news there in terms of management choices. The first one is to enroll in hospice, to decide that you have less than 6 months to live and you want to live those well with the fewest disruptions from emergency room visits and extra procedures as you can get by with. And by agreeing to stop the aggressive treatment for your primary disease, maybe it's cancer, maybe it's congestive heart failure, Medicare will cover the cost for comfort care with hospice. That will include durable medical equipment, like a hospital bed that you can get just the right height for yourself, a bedside commode, a wheelchair, and probably most importantly, comfort medicines. Hospice is an expert in getting the right doses of pain medicines and anti-anxiety medicines that give you the best ability to navigate through your day. And those are provided at no cost in that program by doctors who are specializing in pain management, because that's a lot of what hospice does. So that is all part of the program. They can provide some home support, such as, but they don't really provide very much of what you call the day-to-day stuff, like bathing, changing linens, grocery shopping. So we still need to depend on places like elder help, or maybe going into an assisted living where we get those kind of helps for ourselves, because hospice is not going to come out and change our bed when we've soiled it. That's going to have to be done by home healthcare providers. But it can be a huge game changer from the angst of this desperateness of wanting the next treatment, and then, but hopefully, or finding out maybe that there really is not a good treatment, to an acceptance that we're at the end of our lives and focusing on what do we want to do with the weeks or months that we have left. And I've seen it make a huge difference, the level of calmness that comes over the patient and the family, if they can get themselves into that space. A caveat is that the average time in hospice is something like a week, when you really can be in hospice for 6 months. And it's often when people are just so desperately ill that they finally go home after enduring months and months of unnecessary disruption to their life. So I would encourage you to think that if you see the end is coming, to think about getting into hospice earlier. If you go past the 6 months, you can get disenrolled from hospice. There are a lot of people that went into hospice and are living 2 years later, but they went onto hospice. In fact, some of that's the irony, is often stopping these really toxic treatments, people have lived longer. There's pretty good documentation that some people live longer after they stop what the doctor is recommending with these really super aggressive toxic treatments. Okay, the next thing is the whole issue, and we're very lucky in California. I guess we're one of 10 states and the District of Columbia that has an end-of-life option act for exit medicine. It's not perfect. There's a bunch of caveats here. Many of you know these. You have to apply while you're mentally competent and physically able to lift the glass and swallow the poison, which is basically what it is. The medication is a poison. You need to contact 2 physicians and ask for the medication. And both those physicians have to agree that your life expectancy is reasonably less than 6 months. There's a 2-week waiting period from when the first time you ask until the second time that you must ask to be eligible, even if you meet the other criteria. So it's not an instant take. But once you get the medicine, you can take it right away if the pain is bad enough, or the discomfort, or the overall situation, or you can just keep it as your ace in the hole. And there's, I think, about 1/3 of the people that qualify and have the medicine elect not to take it. They just know they have it. If things get worse, they have a way out. In terms of paying for it, if it's a matter of paying out of pocket, the physician, the 2 consultations and the help from the physicians, and these involve examinations too, finding out what your overall care, reviewing your records. It's not just looking at you. This is a major medical evaluation. And all the paperwork with the state and the pharmacy, it can be between $2,000 and $6,000. So if you're going to be paying out of pocket, you want to shop around. There is some good news with certain programs. I know I'm a part of Kaiser, and Kaiser has their own End of Life Option Act coordinator, and they have a roster of physicians who have volunteered to assist patients, even if they're not their primary care provider, to evaluate them and get them their medicines. So that's really good. Some of the hospices are supportive of End of Life Care Option Act medicine, and some are not. If they're supportive, the medical director can be your primary physician to evaluate you and find a second physician. And if that person concurs, then he can write the prescription for you. And basically most of the cost is covered through hospice. But it's very important to know whether the hospice that you're in is supportive. There are horror stories of people going into a hospice because it was convenient, because somebody else had a good situation with it, only to find out down the line when they're desperately in need of the End of Life Option Act medicine that the hospice does not support that. They just support care until you die naturally. And that creates a crisis for that patient and that family. So just like Barry said, in terms of getting a contract of what your helpers are going to do and what they're not going to do for you, be sure to be clear whether the hospice that you choose supports End of Life Option Act medication and that their medical director will cooperate with you. Otherwise, you're just creating a dead end for yourself. Pardon the pun, sorry. Okay, so now we'll go to the prognosis. If it's longer than 6 months, the first thing you can do is consider just declining any further care for your primary illness. Decline that second or third line of chemotherapy or extra surgical treatments for chronic lung or heart disease. If you really do not feel that they're going to be helpful. That's the first thing you can do. The second thing would be if you develop another serious illness that might be life-threatening, and normally, under other circumstances, you'd be rushing off to the hospital to have that surgery for that bowel obstruction or a severe infection. But in this situation, and this may sound funny, if you're lucky enough to have a bowel obstruction, you just refuse treatment for that bowel obstruction and ask for sufficient pain medicine to carry you through for 5 to 8 days. And that bowel obstruction will be the cause of your death. I have a couple of examples that are close to home. My mom developed breast cancer and over several years had multiple metastases, including to her bones, and started having pathologic fractures. She would just stand up and a bone would break because there was cancer in it. And of course, severely painful. And she was looking at multiple months though before this cancer was actually going to take her life. Well, totally separate from her cancer, she developed acute renal failure. Her kidneys failed. And in consultation with her cancer doctor and her kidney doctors and her family, she decided she would not have that acute kidney failure treated. And over a couple of weeks, she got sleepier. She lost her appetite. She went to sleep. She went into a coma. She was in our home at that point, and it was one of the most peaceful, clearly a very sad event in my life, but one of the most peaceful deaths that I've ever witnessed, because my mom had the foresight to realize that enough was enough, and she had been given this gift of acute renal failure that could allow her to go to sleep and not wake up. I have the other thing you can do is you can refuse medicines for other things or other treatments. If you have a pacemaker, you can have your pacemaker removed or turned off. If you have chronic renal failure and you're on dialysis, you can stop dialysis. You can discontinue your cardiac meds. This is the case, again, close to my home. 18 years ago, my 93-year-old father-in-law, his life was closing in on him with macular degeneration. He was legally blind. He could barely hear. He couldn't listen to his Lawrence Welk shows. And he had congestive heart failure, which gave him anxiety from shortness of breath and angina pain. And on top of that, his wife of 56 years had just died, and he wanted to die with her. And he pleaded with me. He said, "Hunt, you're a doctor. Can't you get me a pill to just end this?" Well, this was 10 years before the End of Life Option Act. And so I told him no. And he suffered for over another year in this very debilitated and very depressed state. But when looking back, there was something I could have done. I could have simply told him, "Vern, you can stop your cardiac medicines." And within a week, he would have died. We could have gotten him morphine to handle his acute shortness of breath and his anxiety, and he would have died in our home quietly. But I consider myself a pretty good doctor, but I'd only been trained to keep people well or try to maintain their life, and didn't even have enough knowledge to know that. And I learned that, of course, through Hemlock Society. And so again, something you can think about. We have more options than we think. Two more things quickly. You can, if these options are not the right ones for you, you can contact Final Exit Network. We've had a presentation by them, and they can teach you about inhaling inert nitrogen gas. You'll stop breathing in about 5 minutes, and your heart will stop in about 5 more minutes, and you will peacefully be lying on your bed, having finished your life with no discomfort or anxiety, because the nitrogen is there to blow off your carbon dioxide. The final one is, if that doesn't work, you can stop eating and drinking. Voluntary VSED, or voluntary stopping eating and drinking, it varies with how healthy you are. You can die as quickly as 5 days, but typically it's 10 to 15 days. After 3 or 4 days of this, you can often qualify for hospice because you are in a state of malnutrition with a life expectancy of less than 6 months. And so you can get a durable hospital bed and comfort medicines. So these are all possibilities for you. Okay, I want to just go back to my slide. I'm almost done. I think, Beth, I have 1 more minute. Is that right? 1 minute. Okay, team, we're doing it. Okay, so what have we talked about today? Well, we've talked about the painful thing that dying is painfully slow and expensive, that not everything your doctor says is really the best treatment, but that you need to talk to that doctor in frank ways and really figure out if they're just trying to give you really unfounded hope, or whether the treatment is really for you. And then if you have a short life expectancy, you can enroll on hospice or apply for the End of Life Option Act medication. If your disease is serious, but is not going to really be causing your death within 6 months, then you have the issues of declining treatments for your primary illness or new illnesses, contacting FAYE for counseling on inhaling inert gas, or voluntary stopping eating and drinking. The final thing is, I want to put a shout out for 2 fantastic organizations. The first one is the Hemlock Society of San Diego. I just did a screenshot here under resources that talks about hospice, palliative care, medical aid in dying, voluntary stopping eating and drinking. And so this is a great resource. And inert gas, that's nitrogen. There are other inert gases, but that really talks about inhaling an inert gas and ending your life in a very quiet way. The other organization is one of our sister organizations, End of Life Choices. They have many of the same resources on their website, but they also have trained end-of-life counselors 7 days a week. If you call them up, you will get a counselor at no charge to go over what these options are, to personalize them for you and get their advice. They also, very importantly, they have a private database of physicians who will participate in prescribing end-of-life option act medicine. Many physicians are not comfortable with it. Other ones will do it, but they don't advertise, and so you have to search them out. Again, this is an issue that physicians were trained in a different era where we were just trying to keep people alive at all costs. And really, we're not facing this issue of the problems with end of life. Okay, I think that finishes my presentation. If there are any questions, I'm happy to try to answer them. That's an extremely good question, and I am not a medical legal attorney, so I cannot answer that with certainty. I guess that my understanding is it is not, number one, it is not illegal for an individual to commit suicide on their own. Number two, it is not illegal to give people information about how they may commit suicide. What does seem to be illegal is if you actively help the person die. On the other hand, one of our mentors, Derek Humphrey, helped his wife die, called the police and said he did it. And now this was in England and he was never prosecuted. Faye may want to comment on that because she's been involved with Final Exit Network, and it really depends on what jurisdictions you're in. But Faye, do you want to make just a quick comment on that? Just that it's complicated, that's for sure.
If it looks to the police like a suspicious death, like you're very disabled and somehow you've managed to shoot yourself or swallow something that physically you couldn't, that might be considered a suspicious death, in which case they would investigate, do an autopsy, maybe find out what happened. Generally, people who are with their loved ones are not investigated and they are not responsible for the person dying. And often when you report the deaths, the police come and they rope off the place and it becomes a big crime scene, which is totally unnecessary and shouldn't happen. But as far as people who are with the person, in Final Exit Network, the person who dies generally is with an exit guide, and that exit guide sort of takes pains to not be discovered, or nobody knows they're present. So it's in Final Exit, Derek Humphrey says, be careful who you tell that you're going to end your own life, and be careful who you choose to have there with you, and be careful that person has an excuse or an alibi when you die. So you still have to take precautions.
Can I mention one thing that, again, something I've learned by being around Hemlock, and that is if you're with somebody who is intending to die on their own at home, for example, it's very, very desirable to have them record for you. You can do an interview with them and they can very clearly tell you on the screen, or tell anybody for later viewing, that it is their wish to end their life. It is their desire. Nobody's coercing them. And literally, they can spell out why they want to end their life. They can explain the pain is excruciating or whatever else might be leading them to do that, so that if anybody ever does question, you have a video or even a written, if they want to provide a written statement as well, signed written statement, sometimes even verified by witnesses. All that is the kind of thing that I would suggest that you would think about getting if you were going to accompany somebody who was going to end their own life in their home.
May I say that one reason people don't do that is because the cause of death would be suicide, and that still carries a stigma. But if you're not worried about that, then that's a very good suggestion, Barry. I agree.
That is an excellent question. And we've had several movies, including A Short Stay in Switzerland, that deals with this issue of kids not wanting their parents to exit. And it is a huge issue. I think the first thing is to start early with, like, just speaking for myself, I've had very frank discussions with both of my daughters and my wife about my wishes. I think they feel a little, I'm kind of a broken record on this one, but I think they've gotten the message that Dad does not want to be kept in a vegetative state. And I certainly hope they will be supportive when the time comes. Probably one thing just to actually think about family therapy, you know, if it seems to be a really big problem in a family, because part of dying well is to die with the support of your family. It might be limited, they may not completely understand, but you don't want that to be the thing that tears the family apart at the end of life. And I've definitely heard of stories where it has been. So I would encourage people to think about that. It's not only like the mechanics of how you might end your life, but all of the pieces within your family that are important to take care of as well. And if that requires some family therapy, I would do that. If anybody else has other suggestions on how to reconcile, Faye?
I was just going to say that's, you know, most people should go to a grief support group when they've lost somebody close to them. The trouble is, if that person has committed suicide or had help ending their lives, it's hard for that the person who's left to talk about that in a regular grief support group. And
good point.
Many of those people do have qualms because I didn't do enough for Dad or whatever. And I don't know of any support groups that specifically deal with loved ones whose parent or kid, God forbid, or sibling or whatever, have taken their own lives and how they handle that.
Yeah.
There is an organization called Survivors of Suicide Loss, SOSL.
Oh my gosh. Really?
Yeah, my
Okay.
daughter-in-law committed suicide, so that's how I came upon that organization.
Writing it down.
Okay,
Thank
great.
you very much. And I would argue that one of the benefits of being in Hemlock is that we have a community of people that believe that rational suicide can be justified under certain circumstances. And speaking of myself, I would be willing to try to help other members, and I'm sure that other people would too, because sometimes you can feel outnumbered. If it's just you and you have 3 kids that are violently opposed for you to end your life, it's going to be really hard. And you may need some extra support people. They may think that you're crazy because you want to do that, but I would argue that we have over 300 members who do not think that it's crazy to take control of
We have a law that says it's okay. It's okay for a doctor to help you end your life.
Yeah, that's a good point, Faye. Yeah, so we're starting to make it somewhat more normal. End of Life Choices California does the same thing. One of their mission statement is to normalize the death process. That, you know, we're all going to die. We don't like to admit that. But any other questions?
To answer that question, some of our members, we've had over the years some death doulas in our membership, and I know we still do. I don't know if any of them are here today at the meeting, but if they are, they might be able to comment on that question knowledgeably.
We've had several speakers, yeah, with death doulas. The basic idea is they, by inclination and by their training, they are there to support people at the end of their life, everything from sometimes doing grocery shopping for them and cooking, but particularly to provide the companionship so that they do not die alone. And at least the small number I know, they are incredibly caring, compassionate people. And especially if people are living alone and do not have a big support group here in where they live, they can be invaluable. Faye, do you want to make any comments or any other?
Yeah, we had a meeting, I think 2 years ago. Our past meetings are on our website.
Mm-hmm.
And that meeting included a lot of people, a lot of different services that you could get at the end of life, people who give them geriatric care managers, death doulas, and couple of other people. So you can go back and see what the death doula said. My hesitation is there's no certification at this point for death doulas, and you don't, it's a sort of a jumble about what they do, what they charge, how you can find them, that kind of thing. But I understand what they do is very helpful. Some of the hospices recommend some death doulas that they have experience with.
Greg, do you have another question? Anything for Carrie while she's still here?
Well, it's a general point that Ken Druck, one of our members, makes, that he has run workshops for family members who are dealing with a chosen death of a loved one. So he's still on board, I believe. He may wish to comment on that.
Yeah, I just would add that having the conversation, creating a safe forum for family members to simply voice what they are dealing with in the aftermath, without judgment, without being lectured, just finding a safe place to have those conversations normalizes that we go through different things. Sometimes we go through guilt, we should have, could have, how did we ever agree? We have remorse. Then other people show that they've struggled with that issue and they've resolved it, and they're good models for other people. But just simply creating, and I would even suggest that this is a good forum to invite family members or a panel of family members who are articulate in sharing what they've gone through and what we can expect. And I think that really informs us about how to more compassionately, sensitively, and effectively help families, because it's the whole family goes through this process. It's not one individual. And in the aftermath, there's an opportunity for people to make peace and to heal. Yeah, this is a book that I wrote to answer that precise question.
Okay.
And it's called Raising an Aging Parent. And the hands you see on the cover are my daughter, her one of my twin grandsons in my hand. But it's raising an aging parent, but it's about raising them up. And it's about how to have those kinds of conversations in our families and what the benefits are and why it's so scary and why we spend so much energy and time in avoidance. And anybody who wants, you can find a copy in the library. I'm not interested in selling them, but you can find it on Amazon. It's also on spoken word for those people who don't like to read and like to listen.
I started to say that on the internet, the web is The Conversation Project by Ellen Goodman, and how to approach the conversation and do that kind of thing. Not necessarily for our topic, but the whole conversation of end of life issues. Conversation Project.
Sometimes people do choose a close relative to be their health agent to carry out their wishes, especially if they don't want all treatments. But clearly, if your close children or other people do not share your values, you may want to think about getting somebody else, either a neighbor, a fellow Hemlock member, someone that can do that. Because if you choose this family member who has not wanted to talk to you about it and does not want to face your death, they're not going to enforce your desires if there are certain treatments that you don't want to have. And so I agree with that. We want to try, and the first choice would be to do it with family, but realistically, if that's not possible, you don't want to give up on, having a good death the way you define it.
Yeah.
And
Also, it strikes me, this is an interesting opportunity in some ways, because I think your experience, that is where you want to talk about these issues and your children don't. I think it's a very, very common experience. I notice even my son, who's very supportive in general of things, in particular, even end of life things, he doesn't want to talk about it. And I think a lot of parents, I can remember my mother when she was, you know, in her 80s wanting to talk about her death. And I would say, you know, Mom, it's too early. Let's not talk about that yet. And it was uncomfortable to hear your parent, loved parent, wanting to or talking about their own demise. So I think it's a wonderful opportunity. In some ways, you're raising an issue that is an important issue. And I think maybe even something in Hemlock that we could look into in terms of, or maybe this would be a wonderful opportunity people who are doing counseling for senior citizens, and to have a counseling service that would deal with exactly that issue.
I was thinking in terms of an intervention where someone would actually come in and help verbalize exactly what this is about.
Well, two things, Marcia, you've brought up a couple of things, and there are several people who can probably help you with that. But there are also these games that I think I have one of them that I had is called The Elephant in the Room, and the cards are shaped like elephants, of course, and they're simple things that start dialogues, and perhaps you get out 3 of those and just simply start it at dinner conversation when you're with your children, if they care to talk about it or not. And perhaps those types of questions that are non-threatening, as in not exactly about death, but something in that arena, could help start the dialogue. Maybe those types of suggestions could help you. And I can private message you some information on those types of things if you would like.
I could just comment that there are no easy answers, and basically you have to do the planning before you have dementia. That kind of goes without speaking, but that's the big answer. And you probably have to activate your death before you really get severely demented. It's really an area where people are trying to push that forward. I guess it's Final Exit Network, right, Faye, that is going to try to push that, where people make explicit commitments as to when they want to end their life, when they get to a certain level of cognitive malfunction. I don't think it's really been tested yet, and I'm personally very nervous about being the test case because I'm afraid I might lose. So I think
Final Exit Network has been helping people with early dementia since the beginning. It's now 15 years old. So that you qualify if you're still mentally competent, you have a diagnosis of dementia, you may be getting worse, but you're still able to do this yourself and express your wishes. Final Exit Network will help you.
Yeah, that's really important. So if you still have that competence and can do it on your own, but clearly that's at very early mild dementia. And right now that's kind of about the only time that you're going to have guaranteed control of ending your life. If you wait longer than that, it's a more slippery slope.
You can also do VSED, voluntary stopping eating and drinking. I just want to say something about Anita's question about talking to people. We have a film series, as you may know, we've had for 5 or 6 years now. Every other month we do a film, a Right to Die film. And movies are about regular people. They're not about laws and stuff like that generally. And they're about how people communicate with each other. And so these movies are like that. And the next one we're talking about is Blackbird, which is about a woman's last weekend on Earth, and she wants her family present. They're not arguing with her, but there are some movies where the family does argue. The one we saw before, Right of Way, is where the daughter thinks this is horrible and calls, guardianships and all kinds of things. So they're an interesting forum to talk about this. So they don't provide answers, but it's every other month, and again Sunday at 1:30. So tune in and get your 2 cents worth in, because we just have a discussion of the films. We don't show them online. We will when we resume meeting in the library.
Faye, you make a really important point there, because those films are really non-threatening environment, and maybe less conflictual environment in which to have that discussion. So I guess maybe what you could do is you could bring a child along who might be kicking and screaming, not wanting to talk about your death, bring them along to that film and watch the film and talk about the film afterwards, as one typically does. So it's a really nice, non-threatening way to start that conversation.
Good idea. I think you should bring your kids to all of our meetings, but yes, especially the film series.